I'm Rashmi Halker Singh. I'm the Deputy Editor of Headache. And today I'm joined by Dr. Andrew Callen, a neuroradiologist at the University of Colorado Anschutz Medical Campus. His work has significantly advanced our understanding of spontaneous intracranial hypotension and CSF venous fistulas. Today we'll be talking about one of his most recent publications, Imaging and Physiology Across the High-Low CSF Fluid Pressure Spectrum, Navigating Diagnostic Uncertainty in Headache Practice. Welcome, Dr. Callen. I'm so excited to speak with you about this work.
Hi, thanks so much for having me.
So your paper really was exciting for me to read, as this is something that I encounter in clinical practice all the time. I want to ask you, first of all, that you propose in your paper about the fact that we often think about intracranial hypotension and hypertension as two distinct entities, but maybe we should be reframing that and thinking about these two as having a shared physiology. For those of us who were taught in an era where these were distinct processes, what's this core shift in mindset that you're asking us to make?
Yeah, that's a great question, and sort of the fundamental question of the paper, and just what we're all doing when we see these patients. And this paper was just, and this concept in general is born from the clinical reality of if you take care of these patients, many will describe to you, some days I feel like I'm in high pressure, and some days I feel like I'm in low pressure. And they have a very distinct understanding that they have different sort of headache phenotypes. And at least I'll speak for myself, we'll sit there and say, I'm not sure what to make of that. I'm not sure if it is truly a high pressure, or if it feels to you that it's high pressure, or and if it is, does that mean we treat it like with the same paradigm that we treat, IIH, but then quickly switch to when you are feeling low pressure? But the symptoms they describe are quite, consistent with our clinical heuristics for those two entities. So, so really, I kind of try to take a step back and think about this from first principles, in the sense that we have a couple of entities that do manifest a phenomenon of going from one to the other, of going from an extreme high pressure state to a low one. And so, for example, this so-called popping the balloon phenomenon, that of the sense that you have a patient with diagnosed bona fide IIH, with papilledema, what have you, all meets diagnostic criteria, who then suddenly has a change in their headache character, and they go into low pressure, and there's imaging evidence of this, and we prove it. So this is the extreme version, but like we can say this exists. We know this. And then the sort of converse to that is the phenomenon of rebound intracranial hypertension, right? Where a patient who has a spinal CSF leak received a treatment for that, whether it be patching, fibrin occlusion, embolization, surgery, and they develop a different type of headache that sometimes we can actually see that there are properties of high pressure. Other times it is simply, and frankly, most of the time, it is simply the patient reporting features that sound more consistent with the high pressure headache. Suddenly it's harder for me to lay flat. I have to be upright. I feel nauseous. My headache has gone from a posterior occipital one to a periorbital one, or a frontal one. And so, if we anchored the conversation and sort of thought process on those two paradigms, then it stands to reason that there are spectrums in between, right? And we are learning more and more about the complex physiology of the CSF space, and particularly in its relationship to the epidural venous compartment, and how these two interact with changes in posture, with other components of physiology. And so I just really wanted to sort of have the paper isn't introducing new data. It's a review. We're just talking about this idea that, look, we're all facing this, and we have to sort of understand that using two extreme bins, you're either IIH, SIH, or nothing, isn't serving our patients correctly, right? We need to do better. And so that's where we started.
So you describe this population of patients that I see in my clinical practice. Sometimes this is the most challenging type of scenario to manage, because just like you described, they don't fit one clear bucket very easily, and it's a diagnostic and treatment dilemma. I'm curious how often you see this, and do you think these patients are being missed in clinical practice as a whole?
Yeah, I mean, so I see it a lot. This is what I do full time.
Yeah.
I see these patients, and it's interesting. I mean, I have patients who are imaging positive. The diagnosis is clear from an imaging perspective, but their clinical story, taken in isolation, is very unusual, but I'm not sure that what we think of as unusual or usual or typical or a good story for a leak is necessarily that, well grounded in data. Um, so if you take just even the ICHG3 positive people, the people with proven leaks or what have you, I hear them say a lot, like, for the first week or so when this happened, it felt like this, then it was like this, now it's like this, then I had a patch and it's like that, this whole sort of saga of different experiences. And then you take the people who are imaging negative, the really challenging group, right, where they've seen a really good headache neurologist. They've been trialed on several therapies directed at a primary headache disorder, and it hasn't helped. And it sounds like it's a CSF leak, but everything is negative. And then them as well are describing different sort of things that happen, different days, good days and bad days, what have you. And so I see it a lot. And I think that the really important thing to do as physicians in this space is acknowledge to our patients that we don't totally know what is going on, but that we want to partner with them and ask the questions and help guide them through this process in whatever evidence we have in an evidence-based way. Because I think that this is missed a lot, to your question. I think, and it's not just that it's missed, I think that patients are dismissed, and then the downstream consequence of that is that they are, people who are suffering from pain don't just go home and suffer from pain. They look for a solution. And if we're not willing as doctors to sort of step up and admit we don't know things and try things in a safe way, in an incremental way, then they're gonna do something else, right? To
Yeah.
help with to try to relieve their suffering. And so this is something that we all have to acknowledge, that this is, if you see if you are in this world at all, you do see these patients, and we have to be better about our, expanding our understanding, and figuring out how we can help people better.
Those are such valid points. Another question for you. In your paper, you talked about these concepts of buoyancy and venous compliance. Can you talk a little bit about that and explain that? What do you mean by that? How does that fit into this framework a little bit?
Yeah, I mean, I talk about this when I talk about the MRI brain, in the context of a CSF leak, right? I mean, people memorize the mnemonic SEEPs, that every
Yes.
little individual finding, or you hear about the burden score and you look for this and you look for that. But I like to think of it more just conceptually. I mean, what are the things that are happening that we're looking for, right? And there are two buckets of findings, of changes, and one is the brain, exhibiting caudal displacement, and we call it brain sag or loss of buoyancy. I'm not sure it's actually is that, honestly. I mean, but I don't. I mean, but nonetheless, we see the brain more caudally displaced, abnormally caudally displaced, and so we describe that with the Bern criteria as a decreased mammato-pontine interval, a decreased pre-pontine interval, and a reduced suprasellar distance. But there are many other ways you could see it. You see the cerebral aqueduct sort of below the incisorial line. You could see cerebellar tonsillar inferior ectopia, lots of things like that. So we see the brain move down. And then the other is the sort of Monroe-Kelly phenomenon. So we have loss of CSF, and then we have engorgement of veins and venous-rich structures to accommodate that loss of CSF. So what I mean by that are not only the dural venous sinuses, the cortical veins, but also the pituitary gland, the pachymeninges itself, even intraosseous veins. Well, can collateralize, and even the skull itself can remodel over time, become thickened in response to this. And we previously did some work looking at, what are the patterns of the findings that patients with CSF venous fistulas in particular present with, because I've always been struck by the fact that, I'll see a patient who has terrible brain sag, but really no dural thickening and no venous engorgement, or others who have very profound diffuse dural thickening and venous engorgement, pituitary enlargement, but their brain is not caudally displaced at all. And so, I think that, and indeed we found that in that analysis that people sort of cluster into these groups, like they would be the SAG people or the venous engorgement people. And I think that that's not only important from a perspective of evaluating imaging and thinking about these things and not dismissing, oh, there's subtle downward displacement, but there's no dural thickening, so it couldn't be a leak, when indeed it could. Um, but also to think about the sort of the clinical manifestations of this, because people who had that SAG cluster in that prior work showed a more atypical headache phenotype than people who had the venous engorgement dural thickening cluster. And when you take that together with prior evidence, for example, the Duke group put out a paper showing that Burns score does not correlate with HIT6 headache severity. So, and indeed, like you'll see somebody with horrible brain sag, and they're like, yeah, I when I cough, I get a little bit of a headache. And then somebody with like a very subtle, a very low Burns score, or maybe perhaps just a venous engorgement, who's bedbound. And you're like, how could this be? Like, is the way that we are taught this, that this disease is manifested clinically by sagging and traction on meningeal fibers? Probably not, right? It's probably has something more to do with something that we're not evaluating well, perhaps, for example, venous distension or the nociceptive relationship of the venous structures to the trigeminal cervical complex, or the epidural venous plexus in the spine and its reactivity, its sort of ability, its plasticity and ability to accommodate CSF. So I think that thinking about it in those two categories not only helps us identify the imaging findings, but also start to think about our patients. What kind of leak is this? Not just is it a fistula or a dural tear, but is this somebody who has a high plasticity and compliance of their venous system and is going to exhibit something that we need to understand? Or is this somebody who's just has SAG with no dural venous, with no epidural venous engorgement, and this might reflect a subtype of this disease that has some important clinical implications that we need to sort of hone in on.
It's so helpful from a clinical perspective as a clinician who sees these patients and is trying to make sense of the imaging findings. I really appreciate that perspective. Another thing that you brought up in your paper was about CSF venous fistulas. And I'm so happy to talk to you about this just because this is a rather newer conversation piece from a diagnostic perspective and something that's coming up more and more often in the literature as well. As a clinician, is there something that we can take back next time we see a patient, we're thinking about this, that we should be looking for in our imaging?
Yeah, I mean, it's very exciting. It's very, from several perspectives, from an intellectual perspective, right? Just reflecting on the fact that there was such a long period of time where people had a pathology that we now can demonstrate clearly that previously we didn't have the tools to demonstrate, and how humbling that we could for just essentially being like, well, that doesn't exist because I can't come up with a way to see what's going on with you, right? It makes us really think about what we're missing now. But also, yeah, I mean, you have a patient in front of you, and what it does is, previously, if your diagnostic paradigm was, okay, the brain MRI should be positive, and I'll acknowledge that sometimes it's not always positive, but a CSF leak is by definition manifested by an epidural fluid collection in the spine. Then simply by getting an MRI of the spine and demonstrating that there's no epidural fluid collection, I have effectively ruled out a CSF leak. We're now dealing with a different problem, which is that, okay, a percentage of patients are going to have a normal MRI of their brain. And also, by definition, a CSF venous fistula will not have epidural fluid in their spine. This becomes very, very challenging. And the clinical decision making is everything in terms of pretest probability. We in that same paper that I referenced earlier that was in headache, we looked at close to 40% of patients in our cohort with the CSF venous fistula did not demonstrate a classic orthostatic headache. So, and my patients tell me all the time, no, if I lay flat, I don't feel better. I have to I sleep at an angle, or I prefer to sleep at a recliner that is sort of at an angle, or it's bad when I get up very briefly. But then when I'm up, I'm okay. But then throughout the day, I'm kind of bad, but laying down doesn't help me, or cough only headache, or acephalgic symptoms with neck pain, or, what have you. So, I think that it's really, really important. And I think that this is something that I really appreciate my headache neurology colleagues for. I have clinic in their space. I'm a guest in their space, but I see patients, and in the beginning, I think other radiologists would look at me and be like, what are you doing? We can go into radiology to see patients, right? We went to read films in the dark room, but it's not just about. It is the better way to take care of these patients, but it's also incredibly sort of enlightening in terms of wow, these things that I was taught about what is the appropriate story for a leak really need to be critically reappraised. And so in terms of what to take away for somebody, I think that you need to be open-minded, right? You need to lean on the things that you know, right? So does this fit a classic paradigm for something that we have more evidence about, for migraine, for some other primary headache disorder? And then you could use imaging and partner with your radiologist to do things to help refine your pretest probability further. For example, not just order an MRI brain, order an MRI of the orbits to look at the optic nerve sheath diameter. Is it distended or is it contracted with very little fluid? If it's contracted, that increases our pretest probability. Look at an MRI of the spine, not with the conventional sequences, but with a sort of CSF leak tailored protocol, only in the sense to get a sense, is there other meningeal diverticula along those nerve root sleeves, which are the substrate from which CSF venous fistulas form. And this can really help you, in a time where our clinical sort of diagnostic criteria, or what you want to call it, is probably very imperfect. We need to sort of get every sort of bit of information we can, because at the end of the day, we are subjecting patients to myelography, which includes a dural puncture, which could subject them to the exact disease that we're trying to treat. It is a good amount of radiation too, and by good I mean bad. And if we have young patients, right? I mean, somebody in their 20s or a teenager, I don't want to irradiate them necessarily and subject them to a dural puncture if I'm not going to help them. Now I'm doing the opposite of what I'm supposed to do as a doctor, right? So, this needs to be a multidisciplinary discussion. And until our clinical heuristics catch up, we need to continue sort of honing in on those non-invasive imaging markers like those, and hopefully others to come soon.
Absolutely. So what I'm hearing from you is like think about the pretest probability, take a careful history, and partner really well with our colleagues in radiology to really, take that next step.
Yeah, absolutely. And the conversation I have with my patients is, it's sort of it's philosophical and a little bit semantic, but it's more. It's not that I don't think we should do a myelogram because I don't think you have a CSF leak. It's that I don't think we should do a myelogram necessarily because the data is telling me that the chance I'm going to find a leak is very, very small. And if I look at this known possibility that I'm going to do something that hurts you, like give you a post-dural puncture headache or cancer in 40 years, and I could say that's a defined risk. And the chance I'm going to find something, while I love finding CSF leaks on patients with burn score of 0, is very, very small. Perhaps we should think about a different way to approach this until the science catches up, right? That is the conversation I have with my patients. It's not that we shouldn't do it because you don't have one. It's because our current imaging and our tests are inherently imperfect, and we don't know the true sensitivity of a myelogram. And so maybe let's keep working on this in a way that is going to maximize your health outcomes, right?
That's such a valuable piece of information for me to take back to my clinic tomorrow. For the headache specialist who's watching this video, what's like the one final thing you want them to take back to that next patient who they see in clinic with this ambiguous problem, from your paper?
I think that I guess the one takeaway would be that we should all be open-minded. That we should all. I think that patients who are experiencing something that doesn't fit into one neat paradigm, they have a classic headache that sounds like IIH, but they don't have papilledema, and their opening pressure is like not really fitting. You know, what would happen if you tried Diamox on that person, for example, and as long as their electrolytes are okay, they don't have liver or kidney problems, and maybe it helps them. Or think outside the box in a safe way, using the tools that you have with your training. Maybe it doesn't. Like, why am I going to try this? Why am I going to try an epidural blood patch on somebody whose brain MRI does not show signs of a leak and they do not have an epidural fluid collection, nor do they have these other markers? Well, if in the right hands, that could be a safe procedure that has demonstrable peer-reviewed literature demonstrating that in that scenario, there is a percentage of patients that could benefit. I think that but your patients are only going to believe you and partner with you and understand when you say listen, what I think we should do right now is nothing, right? If they understand that you really want them to be better, and you're not saying it's not my disease, so see you later. That's how our healthcare system is, right? We're also subspecialized. Well, if it doesn't fit the thing that I treat, I don't know what to do, and don't see me anymore. But instead say, what can I do with the tools I have to help this person, to at least listen to them. Let's schedule a follow-up, even though I did nothing, right? Because you know what? In 3 months, every single week, there's a new paper about CSF leaks and high, low pressure, et cetera. Perhaps we just need to stay on top of the literature for patients, maintain an open line of communication. I think that this is where we live in this world of sort of CSF dynamic disorders, of headache disorders that we can't fully explain or treat, is we have to remain open-minded, on top of the literature, communicative with our patients, honest, and just take it one step at a time, always reviewing the risks and benefits with every individual case.
Well, thank you so much. This has been such a joy. I really appreciate this conversation. I loved reading your paper. In fact, this came out on a day when I was treating such a patient. I was able to share with them as well. So thank you so much for this conversation and the work you do.
Thank you for having me. Yeah, it's great being here.